minutes and we can start. David, are you ready?
5 seconds, right?
Yeah.
Thank you. Go ahead.
Thank you. Second. So welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors meeting. Today's meeting is officially called to order. Please note for the record that Scott French, representing Steve Banks, and Philip Guaido is representing Deputy Mayor Melanie Hartzog, all in a voting capacity. So next on the agenda is the adoption of the minutes for the board meeting held December 10th, 2020. Are there any questions or suggested changes? So may I have a motion to approve the minutes?
So moved.
Let me poll each board member separately. Dr. Calamia,
Yes.
Dr. Shoxi, Dr. Coonings, Philip Guaido,
Yes.
Scott French,
Yes.
Helen Arteaga Landaverde,
Yes.
Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Piñero,
Yes.
Rita Juan,
Yes.
Benioski Peña Mora.
I have a question because I was not in that meeting. Colisha, what do I do?
Well, it's for the adoption of the minutes of that meeting. So,
Yeah, but I was not there, so I.
Correct the minutes.
yeah, but it's just the minutes. We can.
Oh.
So, well,
I guess you can. I don't know. You can.
End them.
I guess. Yeah.
That's
no, Colisha, I was not there, so I don't know what it was said, so I cannot really say anything about
Okay,
the minutes.
that's okay, Fenny. Thank you very much. We do have the votes to carry the minutes. Thank
Okay,
you.
okay.
Thank you.
Okay.
And Anita Kawatra.
Yes.
Thank you. That's a good point, Penny. So the minutes have been adopted. Thank you. So during the executive session, the board received and approved oral and written governing body submissions from NYC H&H Susan Smith McKinney Nursing and Rehabilitation Center, Henry J. Carter Specialty Hospital, and Henry J. Carter Nursing Facility. The board received and approved semi-annual governing body reports, written submissions from NYC Health and Hospitals Amherst. Vendex approvals. Since we began the process of approving contracts prior to Vendex approvals, there are 4 items on today's agenda requiring it, of which 3 have Vendex approvals. There are 10 items from previous board meetings pending Vendex approval. Since we last met, we have received 3 Vendex approvals. We will continue to notify the board as outstanding Vendex approvals are received. Let me then, Dr. Katz.
Dr. Katz is now in with us.
So go ahead, Dr. Katz, President's report.
Thank you, sir. I'm again, as usual, I don't want to read what I've written because you already have it. Right now, we are dealing with the triple challenge, right? Our hospitals continue to be full with patients who have COVID, although I'm happy to say that we have not been overwhelmed, but the numbers continue to go up. Today, more than 600 patients with COVID in our 11 hospitals. But we've been fortunate that because of the success of the T2 effort and New Yorkers being good about wearing masks and social distancing, we haven't had the abrupt increases in cases that have been seen in other areas. And so we've been able to meet the needs of our patients. We have had very low mortality rates, under 10% for hospitalized patients because of the tremendous improvements in COVID treatment. I said triple challenges because we are, while doing that, of course, maintaining our test and trace efforts. As the cases increase, that's more cases that test and trace needs to be able to investigate. We're currently at more than 5,000 cases a day for New York City, which have to be investigated. We are able to do that. We are also hit a new high of tests, COVID tests in New York City of over 100,000 on one single day. And it is definitely all of the testing with prompt results and T2 following up people that we haven't had the tremendous fast increases that have been seen in other places. And then the third challenge, of course, is doing the vaccinations, starting with the healthcare workers in our own hospitals, moving to healthcare workers unaffiliated and home care workers, and then as the governor opened to additional groups, including essential workers, persons over 75, and then persons over 65 included. We've been providing those appointments through our website. The city got up to being able to do 300,000 vaccinations in a week, but then supply did not keep up with our ability to do vaccination. You should be proud that Health and Hospitals, besides doing vaccination at our hospitals, at all of our federally qualified health centers, we are the sponsor of the Bathgate Center in the Bronx, the Brooklyn Army Terminal in Brooklyn, and our 24-hour site at Vanderbilt in Staten Island. So 3 of the 24-hour centers have been health and hospital run. We've had good response. We've done over 60,000 first vaccinations. We're also doing second vaccinations. And we've managed to maintain sufficient staffing for those 3 different COVID-related missions. It has not been simple. People are working very hard to keep it moving. Matt has been doing an excellent job, along with Laura, on our level setting so that none of the hospitals are overwhelmed. Ted has been taking the lead on T2 and the 24-hour centers. Daniel DeBerry, with the amazing work of our hospital CEOs, has been making sure that the sites at the hospitals run smoothly. We've gotten numerous letters that I forwarded you from grateful people, including many who were not our own patients, talking about, how they got an appointment through the website and how delighted they were to see how well the public sector can work and succeed. So it's a huge amount of work. I do want to point out that I've approved the declaration of emergency dated March 1, 2020, which was subsequently updated and has been reissued through February 28th, 2021. For the time period from October through December, the system entered into 2 new emergency agreements, one for transportation services to move COVID-19 test kits to the testing sites throughout New York City on an as-needed basis, and one agreement for family support and child care services related to COVID. In addition, the Office of Facilities Development issued 5 work orders to continue facility infrastructure updates, supporting critical care units and related services, as well as for the 3 new COVID centers of excellence. These agreements and work orders have a maximum authorized spend of $22,628,319. With that, Mr. Chair, I'm happy for any questions or suggestions or direction that the board has.
Thank you, Dr. Katz, and thank you for all the hard work that you're doing on the vaccination efforts, on top of everything else that is going on in the system related to COVID-19 and providing care. So, board members, any questions for Dr. Katz?
Thank you.
Thank you, Dr. Katz. So let me then move on to. One second. Okay, so
The next item is the update from Talia for the beacon.
oh, I'm sorry, yeah. So we have an informational item from MetroPlus Beacon and WBE subcontracting plan. Talia, Dr. Schwartz.
Thank you. And apologies for not being able to be there in person. Don't see the slide deck yet, but it's fine. Next slide, please. Oh, there might be a delay. So I'll get started. The Beacon contract extension came in front of the H&H board on November 19th, 2020, and a request was made to follow up on the MWBE requirement for the contract. Next slide, please. Since then, MetroPlus made repeated efforts to see if there was a way Beacon could comply with our MWBE requirement. A confluence of factors, including the duration of the extension, the clinical nature of the business, requiring close quality assurance monitoring and proprietary software that Beacon is using, as well as MetroPlus entering into a space that could be considered as direct competition to Beacon, made it not possible to meet the requirement. We did follow up with Beacon, and you see in front of you the workforce, Beacon's workforce that works on our contract. See that the majority of the workforce are females, and over 40% of the workforce working on our contract are minorities. Next slide. So our chairperson and I, on the personal level, are deeply committed to enforce our MWBE requirement, as you will see in another contract that will come in front of you today. You can also see the commitment and some of the adjustments that we made, putting MWBE as an evaluation criteria as of October of last year, and also creating a new MWBE policy and procedure requiring to comply with the 30% MWBE certified contracting. So that's my kind of a quick update. I hope this addresses the concern that the chairperson and other board members had in regard to Beacon, and more importantly, kind of in terms of broader approach in our commitment to be compliant with the MWBE policy.
Thank you, Dr. Schwartz, and thank you for also updating us on this new MWBE policy, and that's aligned with what H&H is doing. Any questions from board members? Thank you, Dr. Schwartz. Let me just move on to the resolution. Something here? Okay, there we go. So the first one is to appointing Valencia Lloyd as a member of the board of directors of MetroPlus Health Plan, Inc., a public benefit corporation firm pursuant to section 738520 of the Unconsolidated Laws of New York, to serve in such capacity until her successor has been duly elected and qualified, or as otherwise provided in the bylaws. This was approved by the MetroPlus Health Board of Directors January 8th, 2021. And I'll just, before going through a vote on this, I would like just to say that I had a chance to use Ms. Lloyd, and I am sure she will add a lot of value to the activities of MetroPlus. And as the plan moves forward, she has a lot of experience in managed care, and I'm very happy that about her nomination being move forward. So, any questions from board members?
Wanted to add that Valencia Lloyd is on the line, so if anyone has any questions of her, she's available to take them as well.
Thank you, Sal. Okay, so all in favor of the resolution, say yes.
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 Opposed say no. So the resolution passes. Thank you so much. And congratulations, Ms. Lloyd. So let's move to the next resolution, Sally.
Sally, you're on mute.
Okay, either Raven or, is Raven or Andy doing the next resolution?
We are actually going to share it.
Okay,
If you
terrific.
could
That's all
read
we
the
need.
resolution,
Yeah.
Sally, if you
Oh,
can read
okay,
resolution
I'm
3
happy
into
to
the
do
record,
that.
please.
Authorizing the Executive Director of Metro Plus Health Plan to negotiate and execute 3-year contracts with each of Greenberg, Trowig LLP, Manat Phelps and Phillip LLP, and Shepherd Mullen, Richter and Hampton LLP to provide legal services on an as-needed basis for Metro Plus for a term of 3 years, with Metro Plus having 2 options to renew each agreement for 1 year for an amount not to exceed $2 million for all 3 firms over the potential 5-year term.
Thank you, Sally. I just want to introduce my colleague, Raven Ryan Solon, will be splitting the presentation. Raven is the Senior Counsel and Chief Compliance Officer at Metro Plus, and my partner on many things legal at Metro Plus. So you may be, the plan Metro Plus is seeking to retain outside counsel, kind of a requirements contract where we procure multiple firms and then can make decisions based on a combination of cost, expertise, and other things about particular matters to assign to each. It's a relatively low dollar value procurement, maximum of $2 million over 5 years, but there is actually a funny provision in the Metro Plus Certificate of Incorporation, which requires the H&H Board to approve any contracts for legal services, so that's why we are here. The current legal services contract is with Greenberg Traurig and has been for some time. That expires at the end of this month. They are in the group that we seek to retain again for an extended period, but based on our variety of experiences, I think we determined that it was appropriate for Metro Plus to be able to select from more than just one firm for its work. Occasionally there are issues of conflicts. Occasionally there are specific expertises that might be stronger in other places. And so we thought it was appropriate for Metro Plus to have 3 retained firms that it could consider for any particular body of work. There's been a very positive experience with Greenberg Traurig overall, however. CRC reviewed and approved the procurement process, and the Metro Plus Executive Committee considered and approved this resolution on January 8th. Raven's going to go over some of the key elements of the procurement.
Good afternoon. Can everyone hear me? We wanted to.
Sorry, it's hard to hear.
Okay. Maybe just bring it a little bit closer too.
I remove my mask. Is that acceptable?
Try it with.
Yes, you're 6 feet away.
All right. Good afternoon, everyone. We wanted to just walk you through the RFP criteria and evaluation process that we conducted when choosing the law firms. Our minimum criteria included that legal personnel that would perform any work for Metro Plus must be members in good standing of the New York Bar. The firm itself must employ at least 25 attorneys, ensuring that they have a variety of expertise available. And each firm must have had at least 5 years of experience in New York State managed care. And as you can see, we've broken down our evaluation criteria, including experience, cost billing.
I'm sorry, Raven, I'm having trouble hearing you. Can you adjust your volume?
Yes. And I cannot adjust my volume, but can you hear me now?
Yes, you're fine.
Okay. I could also be very loud. I was indicating that we had broken down our evaluation criteria again into experience, cost and billing and managerial practices, staff development and diversity, and value-added services, which for us include services that are beyond just direct legal services, but are things that a firm could bring of value to Metro Plus. We have the next slide, please. This just lays out the scope of work, and as Andy indicated, these are very standard areas to cover. Most importantly, MetroPlus is an Article 44 licensed health organization, so we want to have advisory work related to statutes and regulation requirements, as well as managed care contracting, any potential advisory work around fraud, waste, and abuse activities, Medicare and Medicaid, which are the largest lines of business for MetroPlus, and any specific activities around those lines of business, as well as standard health information, privacy, and security practices, and any other complex compliance issues that might come up, for which we would want to have the additional support of outside counsel. Next slide, please. So this slide lays out the cost structure and assignment for the use of outside counsel. As was indicated, we are moving from a single firm to multiple firms. However, the status stands that no firm is guaranteed any work under the contracts and under this RFP. Work is assigned by the general counsel or any senior attorneys in the legal department at MetroPlus. And we would seek, if needed, to obtain specific project proposals from the firms to determine who would best be able to serve us given their expertise, and what they bring to the table. We don't expect to have every firm have expertise in every area that we might require assistance or guidance with. And that's one of the reasons, obviously, that we have moved to multiple firms. And some of the firms we've chosen are more expert in certain areas, and some others are, better in others. And so any engagement will be evaluated on those criteria so that we can best use the services as needed, and also to ensure that monies are being used most appropriately. We do have also a chart here for the board to look at with regard to hourly rates. Next slide, please. So at this point, I'm going to turn it back over to Andy to walk you through our MWBE and diversity activities for each of the firms.
So we are seeking a waiver from MWBE requirements for this procurement. We looked for law firms with this kind of expertise in the various state lists, and found there were none. And in addition, no applicants for the RFP had MWBE status. Just a reminder, most law firms are partnerships, which makes it kind of hard to identify, an owner. You can be an MWBE as a partnership, but it is more complicated when these are relatively large firms for the most part by design. And again, none of them with the expertises that we need. No health law firms were listed as MWBEs on the state lists. Subcontracting is not really a viable approach, the kind of work that we typically use. It's not like we have legal proceedings all around the country and could seek firms just to represent us in a particular court or something. It's mostly fairly sophisticated advising on very specialized matters. So firms are generally not willing to subcontract really in any way for that kind of work. We did carefully review the firm's submissions on diversity and inclusion. It was a component of their assessment score, 10%, and we're just going to review some of the self-described programs and other features that each of these firms have, demonstrating their commitment to promoting diversity among their ranks of attorneys. So on the next slide, you'll see for Greenberg Traurig, I'm not going to go over all of this, but I'll let you just take a look. We have statistics on the percentage of their attorneys who are women and minorities, and then certain special awards or features of their diversity and inclusion programs that they have. I will note that Greenberg Traurig is, according to the American Lawyer, #1 in the number of African American partners and attorneys overall, and also #1 in the number of Hispanic American partners and attorneys overall. They're a very large national firm. We actually are working with the Albany office, but that is a designation for their whole firm.
Is the American Lawyer publication, is that considered like the Times of lawyers?
if it's not it's either the Times, the Post, or the Globe. Let's say yes. It's a major sort of magazine for attorneys. Yes, and a very mainstream one. For Shepherd Mullen, just to go to the next slide. For Shepherd Mullen, 36% of all of their attorneys are women, 23% of their attorneys are minorities. And again, this is firm-wide. Those are the statistics that we have. And here are an award and programs that they have to promote diversity and inclusion in their ranks. And finally, for Manette, Phelps and Phillips, same overall statistics, 35% of their attorneys are women, 19% are minorities. It's been highlighted for best law firms for women by Working Mothers, which is not actually a Times, Post, or Globe for lawyers, but for Working Mothers. And then a statement that they provided about their change to their own leadership structure and internal processes, and their elevation of their managing partner is one of the only openly gay female law firm leaders in the country. In our prior procurements of law firms where we have not been able to identify firms that meet, MWBE criteria, we have offered to ask those firms to track the work that is done for us by the gender or minority status of their attorneys. We've started that program at H&H. We can ask the firms, these firms, to do that as well. We are working with the EDI committee to figure out the right kind of reporting and comparisons to make related to that work, but we intend to do that for these firms as well. So in conclusion, we're seeking to enter into a contract with each of these three firms, Manette, Phelps and Phillips, Greenberg Traurig, Shepherd Mullen, Richter and Hampton, effective on February 1st with a total NTE of $2 million over a combined 5-year term, and MWBE waivers were submitted for all of those firms. Happy to take any questions.
Thank you. Thank you for the presentation. Any questions from board members?
Jose?
Yes. So Penioski, Peñamori, go ahead.
Okay, thank you. Again, thank you, Andy, for the presentation. I think, as you mentioned, this is not such a large contract, but definitely it showcases how much in depth you went to both ensure that they have a required expertise for the work that you need, but also looking and asking the questions about the kind of the issue of diversity and inclusion. I have two questions.
Yes.
One is, did they provided their kind of outreach, recruitment, and professional development for kind of increased diversity? I think the last firm shows that they did have their kind of the managing partner to be from a diverse background, but do they share kind of the efforts that they do to increase diversity at all the different levels and how they outreach and recruit from those?
So some of that actually is described in very, very summary form, of course, on these pages. Each of them provided an overview of their programming around that topic. So yes, that was a part of their submission, and they were evaluated on the basis of that for the portion that was about diversity. Many law firms, many large law firms have those programs because of clients like us who are pushing very hard for them to increase the diversity of their lawyers. So it is sometimes, I think, a little bit hard to distinguish among them when they all have programs that demonstrate, real effort, and yet a little bit hard to really evaluate success except with respect to numbers, but when you're looking at numbers across a national firm of 2,000 lawyers, it ends up not having that much to do with who is serving us necessarily.
I will agree, but
Yeah.
for some reason I got muted. Nino. So one of the things that I think this is great that you are asking those questions, but maybe I just put in as a suggestion. Since these firms are very difficult, and I know that you in the last batch of content that you provided, actually you were able to bring MWBE firm that was really kind of very well equipped to address the needs of that we had. But in general, this seems to be very difficult. So if we can maybe have that part of the submission, I know that it is part of the review, but like kind of the whole issue of the outreach, the recruitment, the professional development and the promotion, and with the kind of information of what the results of that, I think that would be great also to do that. So that's one. The other comment that I have is that again, I don't know too much about the world of the legal firms and the partnership, but I believe that a lot of firms, they do use temporary help, and I don't know how they use the paralegal system, if they're all inside or do they subcontract those type of work, but maybe that's an area that one can look at in terms of what is their kind of the pipeline of when they request temporary work or paralegal, if they actually contract that out, to really ask the question, how many of those firms are MWBE or kind of will meet the criteria for diversity?
That's a very good question. I think for most firms, paralegals typically are employees. That's usually not contracted out work. What sometimes is contracted out work is when there are litigations with very, very large document review components. Some firms hire their own lawyers. They call them contract lawyers to do that work. Some probably do some subcontracting for that work. We can ask the firms about that going forward. Certainly we can ask these firms as well. I will say, thank God, that's not a big part of our work. And I'm very glad for that. And hope it remains that way. But that is probably the one place when you have litigations with extremely large document kind of reviews and that kind of thing where some subcontracting does happen. So yeah, we can ask what their arrangements are, even though it might not be on our work.
Yeah, I think asking the question may make them think a little bit more about it. And again, to look at what are the opportunities. And I know that at the level of the actual attorneys is a lot more difficult, but there are other types of kind of resources that they may tap into that we will want to ask holistically. Okay, thank you.
Thank you, Konyoski. Any other questions from board members?
Jose, I have a couple. That's
Frida, one, go ahead.
Thank you. So one, first just clarifying, Andy, I think in the presentation, and I think you stated that it's $2 million over the 5 years, but in the summary page, it says $2 million per year. So I just wanted to, maybe we can clarify that for the record.
Oh, no. Yes, that would be a mistake. It's the budget is $400,000 a year and it's a 3-year contracts with 2 1-year options to renew. So a total of $2 million. So we'll look to correct wherever that is. Sorry about that.
Perfect. And is that sort of like, does the $400,000 a year roughly what Metro Plus spends on, you know, some inflationary factor perhaps, but that's generally what legal services have been?
That's consistent with our historical spend on outside counsel.
Okay. And would these lawyers, or would these firms, excuse me, be the only pool of attorneys you could use? Or if there were certain special situations that come up, you would just be able to do another?
Exactly.
You're not tied to using these firms for all your...
Correct. For example, you may have heard about another one, a specific situation, we occasionally will use a firm if it's not for work that is like expected and wasn't really procured for, but that would require special authorization.
Okay,
These
so
would
that would be
the ones
outside of this contract approval.
Exactly.
Got it. Okay. And then I think the other point I just wanted to pick up on was what Fenny was talking about. And I think, it is difficult, obviously, on the subcontracting in this space, and then pursuing making sure that we look at the diversity and inclusion initiatives and what the makeup is of their attorneys is very important. And, I noticed that they're all relatively the same. That is a national look, I assume. It's firm-wide. Are you tracking and encouraging sort of at least the team that works with H&H and following, what does that makeup look like? And number one, I guess I'll pause and let you answer that.
So remember, these firms we haven't procured them for Metro Plus yet, so we're not yet doing that with these firms. With the H&H firms, we've talked about this before. We have started tracking it, and then that has started conversations about how can we, what are ways to work on improvement. As a typical matter, we have relatively small teams working for us, maybe somewhere between 3 and 5 attorneys who do a vast majority of our work. And of course, there's not like turnover all the time. It's actually better for us not to have turnover all the time, because they really are expert and know our work. On a larger matter like a litigation, that's when more people kind of get involved. So I will say there's one firm that we've worked with. They know that this matters to us. They were excited that a young associate was joining their team, a diverse associate. They worked hard to get that associate to be part of this team, and that, we would consider, a nice win, and that associate has done terrific work. And hopefully we'll be with them for a long time, and we'll, maybe someday be a partner for them, you know what I mean? So I think that the message gets to them that it matters. The opportunities for change it's a little slow, because we don't, people are not coming and going, and we don't actually use very many very young associates. We mostly use people a little bit later in their careers.
Yeah, and I recognize that is very difficult. And I think just along the lines of what Fenny was trying to say, but is there ways that we can, I think, and I just think about our own reporting on our, as opposed to here's the percentage of all of our attorneys across the board, looking at, because if there's not a pipeline, right, if you don't have it, so it maybe it's the partner level might not be so great, but the associate level is greater. And so we have pipeline, and how are we developing our younger people to create a broader representation across all levels and then across the firm. And so asking for both a more, a deeper look at what they're doing, I think can help parse through some of these plans. Like you said, everybody has a plan, right? Everybody has
no, you're absolutely right.
To do, but data helps, and then trying to tracking that data to have, metrics and see that there's a progression. And so that's not so much in evaluating and selecting right now, but kind of going forward,
partnering and pushing like what's important to us.
Right. So if we're contracting with these firms, like saying we would like to see the progress, right now you're 35% and 20% or whatever it is, female and minorities, where's that going? And could you break that down in more detail as opposed to just an overall statistic? So I think that would help
incredibly well taken point. Yeah.
Move that forward in general for our professional services contracts, because I think this comes up.
Exactly. I think, and I will say, it's in development are sort of some more data-based approaches to looking at things like professional services where the MWBE opportunities are maybe not as significant, but like we really need to pick our pick our goals. And I think we're on the path of that, and that will lead to better, sort of procurements that can ask more targeted questions and that kind of thing. So it's a very good point that we agree with and are working on. I mean that sincerely.
Great. Thank you.
Yeah.
And I'm happy to talk to you about some of that too, because obviously we deal with that in our own world as well, my own world. So
I would really appreciate it.
Great.
Thank you. Any other questions from board members? Actually, on that note, I think just playing the video of this at about minute 40 of the video, and we'll make it very clear to anyone how important this topic is to law firms or to anybody that is interested in working with H&H. So let's move to a vote then. On this resolution, give me 1 second. So I'll call each of us one by one. Dr. Katz.
Yes.
Dr. Calamia.
Yes.
Philip Waddle. Philip. Scott French.
Yes.
Helen Arteaga Landaverde.
Yes.
Barbara Lowe. Barbara. Robert Nolan.
Yes.
Sally Hernandez Piñero.
Yes.
Frida Juan.
Yes.
Benioski Peña Mora.
Yes.
And Anita Kawatra. And myself, yes. So the resolution is approved. Let's move to the next one. Sally Hernandez Piñero, number 4 on the agenda.
Okay, authorizing the executive director of Metro Plus Health Plan to extend its contract with Milton Samuels Advertising Agency to provide media buying and creative services for an additional 6 months to August 12, 2021, and to increase the not to exceed amount by $1,750,000 from the current not to exceed amount of $19,100,000 to $20,850,000. And I believe Catherine Solman is making the presentation on behalf of Metro Plus.
I am Sally. Can
Great.
everybody hear me?
No.
Bring it a little closer to you.
Okay, I'm just going to pretend that I'm a singer. Okay, so good afternoon, everybody. Hope you and all your families are doing well. I'm going to talk to you a little bit about, very briefly, the background of this request for an extension of our contract. So, Metro Plus Health, we're seeking to extend our media buying and marketing contract with our current agency, which is MSA, Milton Samuels Advertising. We're looking for a 6-month extension, and we would increase the spending authority by $1.75 million. Currently, the plan spends on per contract year $3.5 million with MSA. We require an outside vendor for these services. It's a lot of complicated work. It's advertising, it's marketing, production, and it's something that we really can't efficiently or cost-effectively do in-house. So MSA creates and produces for us a wide array of products, collaterals. They subcontract all of our ads for us. They support our plan, both in terms of us meeting our regulatory requirements, but also in terms of us being able to contain our costs, to have the highest quality that we can have, and also to reach our multiple marketing goals. So, MSA was awarded the contract last time in 2016 through obviously an RFP process. Our current contract with MSA expires February 12th of this year. And the board of directors, our board of directors, Metro Plus Health, approved the resolution December 22nd, 2020. Next slide, please. So let's talk just briefly about their past performance highlights. There are many. There's a lot of work that Metro Plus Health is doing in this sphere. MSA is handling a lot of projects for us. So one thing is, for example, when the launch of the Essential Plan occurred, MSA did a lot of market research, took into consideration what were we learning from people who would be eligible for this type of plan. And the idea was really that it was the lowest cost health plan in town. And it was a bit of a double entendre because not only was the essential plan the lowest cost health plan in town, but we were. And so what we did, we ran that through all the usual integrated marketing venues, so TV, radio, print, digital, social, et cetera. And we did end up with the highest enrollment of our types of plans in the city in essential plans. So I think that was quite a good achievement there. They also rebranded and repositioned Metro Plus Gold. As you all know, Metro Plus Gold a few years back was rolled out to all New York City employees. And what we did with that one, with television, radio, print, a lot of interesting social and other projects, was we saw that first year there was a jump of membership by 45%. So that was year one, and year two, an additional 30% growth. Interesting for people who are in this room is that MSA also recommended a much stronger co-branding approach with health and hospitals. So we worked with the H&H team to figure out what was the best way to do this, and we arrived at a co-branded advertising, which we use in various things, sometimes on subways, sometimes on bus shelters, print ads, social, and the tagline is Proud Partners, NYC Health Plus Hospitals. They also developed for us a Good For You campaign, which basically was, it started just as mostly with our radio sponsorships, which we do quite a lot of, but it sort of has extended into something that we use in a lot of instances when the things that we're doing go beyond just healthcare and maybe enter into wellness and other topics that we think we can offer value to members and to general consumers. So the core services that are being provided by MSA will not surprise you here. We've talked about some of them already. So ad creation, media buying, TV, video, radio, social, redesign of website, obviously brochures, et cetera, content marketing. But they also provide for us quite a lot of value added. For one thing, they've worked with us for a bit of time. They know us. They also work with H&H. They know H&H. So they've been able to do a lot of things for us, like focus groups. They've branded our kiosks and our office designs. They've done a lot of radio sponsorships and things, and they've also done a lot of event planning and support for us. So next slide, please. So the financial overview just sort of takes you through a rough idea of how this $1.75 million might be spent over a 6-month period. And obviously, it's provisional. As you see, we just saw that the marketplace is going to be open again through March, through the end of March. So where you see that spending for February, we already know that we're going to be increasing it because we're going to need to. The marketplace is open throughout February. But this gives you a rough idea of how we would divide up the spending by month and by type category. Next slide, please. So as Dr. Schwartz was talking about earlier, we've made a really strong effort to really increase our MWBE spending with the partners that we have. So for most of the year, MSA was spending about 11% of the contract value on MWBE. However, we really upped the spending in Q4. So it hit more of a 23% of the spending was going to MWBE partners. So as you see, the total Q4 spend was that $870K. The MWBE total spend was just over $201,000, and then the non-MWBE was $668K. But what they have committed to doing, and as you can see, they're moving their way up there, that for this extension, they've made a firm commitment to hit, if not exceed, that 30% target. And here you see, to the right, a list of some of the vendors we work with who are MWBEs or MBEs. And you can see by the names that it moves throughout a variety of diverse groups that we're working with. And all of these vendors are certified with the city or the state of New York. So next slide. So in short, we are seeking your board approval for this 6-month extension with Milton Samuels Advertising for media buying services. We'd like to increase the spending authority by $1.75 million. It's a 6-month term, effective February 13th through August 12th of 2021. and it should not exceed the $20,850,000 for the total duration of the contract. Thank you.
Thank you so much. Any questions from board members? Okay. Peñamora? Go ahead.
Thank you, Mr. Chair. I just have a question, just for clarification. So the total contract now is going to be 20,850,000. And so have we spent all the 18 million already? Because you're only asking for almost like 19 million, a little bit more than 19 million, because you're asking to increase to 1,750,000.
Well, by February 12th, we would have spent all the dollars that were allocated to a 5-year contract. So because the contract's ending February 12th, we're looking for an extension, which is really basically half a year on what would be a new contract.
Oh, okay. And so, and now their commitment to MWBE is for 30% of the 1,750,000.
Absolutely.
Okay. Okay. Thank you. I also, just to ask you a question, maybe I missed something, but when you were listing the number of newspapers, I didn't see kind of the Asian community. Is that part of that or not?
We do advertise with various Asian publications. Some of them they're not listed on there. And off the top of my head, I'm not sure that all of those are actually MWBE. So I would have to go back and look.
Okay, okay, thank you. But your campaign is very broad and diverse in trying to reach all the different communities. Is that correct?
Yes.
Okay. Thank you.
Thank you.
Thank you. Any other questions from board members?
I think
Yes.
I'll add
Uh,
that.
Sally?
Yeah,
It's
I was
Bob. It's Bob. I have a question.
Yeah, let's Sally. Sally was gonna go first, and then Bob.
I
Go ahead,
just
Sally.
wanted to add, Fenny, that because of the constituencies we're looking at, we have very narrow geographic targeting as well as targeting to specific groups. So we are deeply, deeply immersed in, we'll look at the Haitian community, with the West Indian community. It's like very granular focus for our advertising.
Thank you, Sally. Dr. Robert Nolan, go ahead.
Thank you for the promotion, Jose. I appreciate it. I noticed that the contract extension expires in the middle of August. Do you then anticipate coming back before the board in June or July with another contract?
I would say yes. We will have to be working on an RFP. We're working on one now.
Gotcha. Thank you very much.
Sure.
Any other questions? Okay, so let me then take this to a vote. Second here, Dr. Katz.
Yes.
You, Dr. Calamia.
Yes.
Philip Waddle.
Yes.
You, Scott French. Helen Arteaga Landaverde. Barbara Lowe. Barbara.
Yes.
Thank you. Robert Nolan.
Yes.
Sally Hernandez Piñero.
Yes.
Frida Juan.
Yes.
Penioski Peña Mora.
Yes.
Anita Kawatra.
Yes.
And Jose Pagan, yes. So the resolution has been approved. Thank you so much. And I hope that this is very useful for our 5-star plan. Let me then, give me 1 second. Get organized here. The committee, due to a virtual meeting setting, the committee and subsidiary reports were emailed to you for submission into the record. Are there any questions or comments on those reports? Is there any old or new business to come before this board? If there's no further business, I declare the meeting adjourned. Please stay for the board members. Please stay for the ACO sole member annual meeting. We can get started, right?
Yes, you can.
Okay. So our HHC Accountable Care Organization Sole Member Annual Meeting, today's meeting of the HHC Accountable Care Organization Sole Member Annual Meeting is now called to order. Please note for the record, Scott French is representing Stephen Banks and Philip Waddle is representing Deputy Mayor Melanie Hartzog, all in a voting capacity. So next on the agenda is the adoption of the minutes of the HHC ACO Annual Membership Meeting held on December 19th, 2019. Are there any questions, comments, or suggested changes? So may I have a motion to approve the minutes?
So moved.
Let me have a quick vote. Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Philip,
Yes.
Scott French, Helen Arteaga Landaverde, Barbara Lowe,
Yes.
Robert Nolan,
Yes.
Sally Hernandez Piñero, Frida Wan,
Yes.
Benioski Peña Mora,
Yes.
Anita Kawatra,
Yes.
and Jose Pagan, yes. So the minutes have been adopted. I will now turn the meeting over to Matthew Ziegler, our CEO of the ACO, to present the resolution for adoption and provide an update of the activities of the ACO.
Thank you very much. Perhaps first I'll read the resolution and then I can take folks through a presentation on the great performance of the ACO this year. The resolution is authorizing that each of the following persons be elected, effective immediately, to serve as a director of HHC ACO Inc., the ACO Board of Directors, in accordance with the laws of the state of New York. Those individuals are Mitchell Katz, Matthew Ziegler, John Ulberg, Andrea Cohen, Gary Calcutt, Nicole Jordan Martin, a new addition to the board, Dr. Jasmine Moshepour, Dr. Luis Marcos, Dr. Warren Siegel, Lori Donnell, and Hyacinth Pert. So with that resolution read into the record, I will first. Okay. So the resolution is read into the record. If a board member shall we vote on it now?
Yes.
Okay. Can I make the motion?
Yeah.
Should
Do I have a second for the motion to vote on this resolution?
Seconded.
Second.
Okay.
Um,
All in
okay, so-
favor?
Yes.
Yes.
Yeah.
Yes.
Yes.
Any opposed? Oh, great. The resolution carries. Thank you very much. We're thrilled to add Nicole Jordan Martin, who's the leader of our community care division, to the board of directors. They're a key partner for the ACO, as I'll mention in this overview. Several members of the board are familiar with the work of the ACO, so I will move through this quickly and hopefully leave time for questions. Since I took over as CEO following in the filling the big shoes of Dr. Chosky, our former CEO, David Stevens has been appointed our new Chief Medical Officer of the ACO. He also leads ambulatory care at Kings County, so we're thrilled to have that close connection to delivery of care, one of our largest and most important ambulatory care practices, to the work of the ACO. Next slide, please. As board members know, our performance in performance year 2019 was one of the best the ACO has ever had, the second best precisely, generating shared savings, a performance payment of $4.6 million. Our quality score increased meaningfully from the prior year. And while our number of assigned beneficiaries declined slightly to 9,000, that is due to a change in the methodology. We now have beneficiaries assigned to us at the beginning of the year. We track their care and performance throughout the course of the year, and we know that we are monitoring them rather than having them assigned to us after the fact. So it's an improvement in our ability to follow that and manage their care. Next slide. The next slide goes into a bit more detail about how we generated the financial returns we did this year. This board, the ACO board, Dr. Chosky and I worked together on making the ACO move to the next track of ACO performance that the Center for Medicare and Medicaid Services allows. So middle of 2019, our performance moved into that enhanced track, which puts us at risk for losing money if we do not perform. But if we perform well, we have the opportunity to earn significantly more, which is what we did this year. And so you see in the second half of the year, we generated over $3 million in performance payment, which we are very happy with. Next slide. Our clinical quality performance was also stronger this year, which we were proud of. It was largely flat. The sample size is somewhat small, but there was both a significant reduction in one of our hospital admission and readmission measures, and then an increase in unplanned admission. So a bit of a wash in some of those quality measures that CMS is tracking, but overall the ACO continues to perform well on clinical quality measures. The next slide just takes you through a little bit of how efficiently the ACO operates, even with a very vulnerable and challenged patient base, particularly in the year of COVID-19. The top slides show the slow growth in our expenses over those years. Our clinical care expenses, only 1.9% growth in medical spending is very low in the context of the American healthcare system. And as you see at the bottom and on the right-hand slide, a significant change in our utilization and the amount of spending based on COVID-19. Our patients were sicker. More of our patients had COVID than typical ACOs around the country. The next few slides just take us through the ACO's operations and some of our strategy. I've been through this with several board members before, so I apologize. I will move quickly and then come back to this. Happy to talk offline with anybody about it. But the key is really dedicated clinical care teams who focus on these patients and good data that the central ACO team feeds them, and then coordination by the ACO team and others with multiple offices, both at the central office level and then at the point of care. We really want to be focused on patients with chronic advanced illnesses with a Medicare population, which is what we have over age 65 typically. That is really the main driver of unnecessary hospitalization and expense, and really where the ACO can bring unique value to the system. Next slide. Some of our goals and work streams for this year are to generate some expected practices for clinical care and care coordination for some of our highest risk patients. We're going to continue our focus on quality, the gaps in care that our patients have and how we address them. We'll continue to improve our data and analytics work, which I think is very strong, and we are beginning to spread and use more across all of our managed care and other value-based payment activities around the system. And then we provide administrative support just to administer the ACO program and distribute the shared savings that our doctors and care teams have so effectively earned. This is Dr. Stevens and our team's model for the care of our high-risk patients, identifying the patients, bringing those expected practices to bear, driving those improved patient outcomes, and then seeing the financial outcomes that we all hope and expect and have seen in recent years. Next slide. So specifically, some clinical activities that we're focused on this year are these high-risk expected practices. We will then be really trying to drive towards improving upon our annual well visit performance. This is a key quality measure and a covered benefit, an important benefit for Medicare populations that we will try to do a better job of getting patients in for. It is a challenge in the age of COVID having elderly patients come in for in-person visits, but our work around telemedicine has been very important. We're working to improve a directory of community-based organizations that serve and can help our high-risk patients. This exists in pockets around the system, but trying to centralize it and build it up, we think will be a great resource for us and others around the system. We are developing and funding a self-management coaching program This is a critical tool for our patients to be able to take home and help themselves advance their care and work with us when they are not in the physical presence of a physician or care manager. And then we are, with community care, developing an integrated care model that focuses on congestive heart failure, which is one of our largest areas of unnecessary or avoidable hospitalization and emergency room use. So building community health workers' expertise in caring for CHF patients, and then feeding them data and connecting them to our patients as far upstream as possible, as well as linking them closely with our cardiology specialists around the system so that we can more closely monitor these patients on the outpatient setting and help them stay out of the hospital. So those are some of our activities. Again, I went through it quickly because several of the board members and I talk about this regularly, and we had a discussion in December about it. We now have a quorum and are thrilled to have all the board members here to hear about it. We're thrilled with our new board member, and we're looking forward to many more years of success with the ACO. One note just for the board members about COVID-19 and the impact on the ACO. There have been a significant number of waivers and things from CMS that reduce the risk of our loss. So we do expect another good year of performance in 2020, despite all the disruption of patients not coming in for certain services or coming in for COVID-19, unfortunately, in greater numbers. And so that is our report on the ACO, and happy to answer any questions. Great.
Any questions for Matt?
Jose?
Yes.
And Matt, I'm sorry, because I think I've only heard one ACO presentation. And so these are simple questions, I have to say. But how do we identify our patients? Where do they come from?
They're identified for us by the Medicare program. So they are patients who use our system, right, and have fee-for-service Medicare, okay, and are therefore assigned to our ACO because we have created the program.
I see. Okay. Thank you.
Jose, I have a question.
Go ahead. Go.
Hi. Thank you, Matt. Again, wonderful work, and again, it has been a kind of a stellar program. My question is, maybe I don't know if Deb is in the call, but with the changes in administration, are there any signs that there may be policies that will be more favorable to the ACOs, or are things going to continue the same way that they are? Are we thinking ahead? Are there discussions that we can maybe influence because we are a large kind of organization that make use of this program that we can influence? Now we have a lot of leadership changes that may indicate an openness to hearing our concerns based on our experience. I know that this is not something of what is happening today, but it's kind of trying to look in the future and how to shape the discussion so that it will be kind of favorable based on our conditions.
Yeah, no, I think it's a great question, and from prior experience when I was working in Washington D.C., the teams that are coming into the Biden administration are the teams who created ACOs, right? Who wrote them into the Affordable Care Act, wrote the regulations, and are committed to their success and improving upon them. So I think we are certainly, based on just the personnel, well positioned for more steps towards value-based payment, encouraging it at the federal level, moving away from fee-for-service. I think the complicating factor there, of course, is that in the midst of a pandemic, it is a difficult time to make major adjustments to reimbursement methodologies and systems at the Medicare level, right? I think there would be a lot of opposition about that. So my sense is that the Biden administration will not be trying to rock the boat dramatically and shift away from fee-for-service payment models towards value-based payment. But I think overall they are predisposed to do that. And my hope is that the disruption of the pandemic and the understanding that primary care practices in particular have been very hard hit by patient volumes going down. And what they really need is fixed revenue streams and to be reimbursed by the quality of care they provide, not just the number of patients they see and the number of things they bill for. So I think, as we see our way through this pandemic and finding a way to balance out, you don't want to penalize an ACO because not that many people wore masks in a region, right? And more people wound up in the hospital. So they have this balance to strike between how to advance value-based payment while how to account for the unique circumstance we're in with the pandemic.
Thank you, Matt.
Sure.
I have a question, Barbara Lowe. Hi, Matt.
Hi, Barbara.
I know the ACOs have gone through so many twists and turns since its implementation, and we've done very well consistently. I see that there are some new modernizations like Part D and other things on the horizon, which is not within our control, but we usually get up and going very well. For those kinds of forward-thinking innovations that are planned at the national level, how do you feel about our ability to make sure we stay on track with them as well as what our needs are?
I feel very good about it. I think, as I was saying, certainly in the era of the pandemic, we still want to strike this balance between driving innovative payment models and accounting for the things we can't really control for, which would potentially hurt the ACO, which is the amount of COVID spending that has happened for our ACO patients. But overall, I think Deb and I in particular feel very good about our relationships with the incoming Biden administration. Senator Schumer and members of the House leadership are as well, and I think when and if they make moves to advance and make changes to the ACO program or other things, I think we will have a friendly audience and people who want to listen to us and make these payment models things that work for safety net institutions like ours, and not just suburban hospitals or other primary care practices. We are, if it can work for us, I think it will be a real point of pride for their policy agenda. So we're hopeful that
I agree. I hope that we can lead in certain areas, actually.
Absolutely. I agree, and would love to work with you on it.
Thank you.
Any other questions? Matt, as a follow-up to actually what Barbara was mentioning, in a way, part of the reason for having the ACO is not necessarily a savings, but it's providing better care for our patients, which we do and so on. But another key issue for us that the ACO is sort of a lab to test ideas on how to reach out high-risk patients and so on. So I think in a later report, it would be interesting to know more about how knowledge acquired from the ACO transfers to other units at H&H. Not only H&H itself, but also the FQHC and also Metro Plus. And I don't know if there's a way of documenting that or thinking about how that's happening, reflecting upon it. That maybe a few months from now or in the next annual report, you can touch up on that.
Yep, I would love to do that, and I think we're thinking exactly along the same lines. All these key clinical initiatives that I have here, I'm actually dividing my team's time and the budgeting of the team so that all of these activities are spread across our payers, right? But the ACO team has to work on the ACO, but if a portion of their time on these specific activities should all be dedicated to other things we're working on. Nothing we build should be just for our 10,000, 9,000 ACO patients. It should be for all 1 million health and hospitals patients. So I think that's a great thing. And certainly on these 4 initiatives and other things that we're working on, happy to report on how many non-ACO patients these things are touching and how we're building the things discovered in the ACO into the day-to-day operations of health and hospitals Metro Plus and other partners.
Thank you, Mike. Any other questions? Okay, so is there any old or new business to come before this board? If there is no further business, I declare the meeting of the HHC Accountable Care Organization sole member annual meeting adjourned. Thank you so much.
Thank you.
Jose, we finish all the meeting?
We are finished today.
Okay, good. Thank you. Nice seeing you all.
Nice seeing you.
This meeting had like 19 parts to it.
We did it.
Yeah. Okay, have a wonderful evening, everybody.
We were
See
very
you.
safe.
Bye-bye. Bye-bye.
Take care.
Thank you.
Stay
Be well.
safe.
You too. Bye-bye.
Everything, are you meeting with Eric? Everything going okay? Okay. Okay, good.